Hello, dear friends. Very warm welcome to all of you at our conceptual brainstorming integrated session of anatomy. Myself, Dr. Shrikant Verma. So we are starting this very important topic, breast. Right now, the direct question from the anatomy part, it is not asked generally, but yes, it is very important for the surgery, for the medicine, for your pathology, as well as the obs gynae. So we are going to look for this. Before starting the session, few positive lines. Yes, a mind is like a parachute. It doesn't work if it is not open. So open your mind and absorb the knowledge. First of all, what are the different points which we are going to learn in this portion? Unit intro. We are going to look for the our definition, then we will see the location of the breast, then we will observe the quadrants of the breast, then bed of the breast, structures of the breast, then arterial supply, then we will see the very important topic, lymphatic drainage, because the breast carcinoma, one of the most common cancer in the world, yes, especially in the female, it spreads through the lymphatic drainage. That's why it is important. Then also one short note we will prepare for the clavipectoral fascia. We will look for our different clinical points. Let's start this session one by one. First, what is the definition, how we can define, and what is the MCQ related to it? Sir, breast is modified sweat gland. So this is the MCQ. Sir, it is modified sweat gland. This is important question already asked. Yes, you can remember that mother is giving the modified sweat to the baby. It is present in male and female both. But remember, it is especially very well developed in female after puberty. Yes, it is well developed in female after puberty, and it is located at which area? Sir, pectoral region. Okay, sir. So in this way, you can define the breast. Now, try to understand the location and the quadrant of the breast. Sir, the breast is very well developed in female after puberty. It is located at the pectoral region. So you can see the extent. Yes, the superior extent, it is starting from the second rib. You can remember the sternal angle. Then the inferior extent, it is extending up to the sixth rib. Now you can observe the medial extent. Sir, this is our medial extent. It is starting just lateral to the our sternum, and the lateral border is ending at the mid axillary line. So these are the points which you can remember. Now try to understand the quadrants of the breast. It is important for what? Sir, it is important for the mass diagnosis or any lesion located at the breast. When you will go for the surgery, when you will go for the clinic, you have to locate any lesion or the lump. It is present in which portion of the breast. That's why. So try to catch this point. For the study purpose, you can divide the breast into the four quadrants. Suppose this is the breast. Okay, sir. It is having the conical projection known as nipple, and around the nipple there is the pigmented area which is known as the areola. Fine. So you can divide the breast into the four quadrants. Yes, sir. Suppose this is medial side. So here you can say upper medial quadrant. Then you can say the lower medial quadrant. Then you will observe this is our upper lateral quadrant, and here is the lower lateral quadrant. I think there is no problem. Upper and medial side, lower and medial side. That is the upper and lateral side, and that another one is the lower side but lateral side of the quadrant. So four quadrant you can divide. Now try to understand from the our upper lateral quadrant, there is the extension of the breast towards the axilla in a projection form. So this was studied by the one anatomist Spence. So this is known as the axillary tail of Spence. Yes, sir. It is the MCQ that axillary tail of Spence is extension of which quadrant, sir? It is the extension of the upper lateral quadrant. Now remember, the breast is located within the superficial fascia. This is another important question. The breast is located within the superficial fascia. It is not located in the deep fascia. That's why this is freely mobile. Breast is the soft structure. Yes, it is containing too much amount of the fat. It is located where, beta? Sir, it is located in the superficial fascia. But this axillary tail of Spence, yes, it is going towards the axilla and it is piercing the deep fascia. So it is creating one opening, sir. It is piercing the deep fascia and it is encroaching deep to the deep fascia. So this oval opening in the deep fascia is known as the foramen of Langer. So this is the another MCQ. The breast is superficial structure, but its tail portion, it is piercing the deep fascia, creating one oval opening, and through the oval opening, the small portion is getting fixed within the axilla. So this oval opening was studied by the Langer, foramen of Langer. Yes, and this projection from the upper lateral quadrant is known as axillary tail of Spence. Hope you are getting the point. These are the different MCQs. Okay. Now look for the next. Sir, here in the image, foramen of Langer and axillary tail of Spence had been shown. Now come for the bed of the breast. Breast cancer is one of the most common cancer of the world in the female. Okay, sir. So when you are doing the surgery for the breast, yes, at that time you must know what are the different structures located at the bed of the breast. So try to catch. You will do incision, skin, then superficial fascia. Within the superficial fascia, breast is located. Deep to it, there is a deep fascia, and that deep fascia is simply known as pectoral fascia. Okay, sir. Now try to catch this another point, sir. Just behind the breast, there is the one loose connective tissue layer that is a retromammary space. Fine, sir. Now try to catch this another point. Retromammary space is there, pectoral fascia is there, and deep to it there are the three muscles. What are the different three muscles? Can you see? This is the pectoral region. So the big muscle at the pectoral area, sir, that is our pectoralis major. Yes, it is our pectoralis major. MCQ. Now on the lateral side, can you see there is a boxer's muscle? Yes, sir. This is our serratus anterior muscle, and one muscle which is running downward forward medially in the abdomen. Yes, sir. Here there is the presence of the external oblique muscle which is presenting as the flat tendon. Flat tendon means aponeurosis. So you will say flat tendon external oblique aponeurosis. So you can remember one mnemonic, the three muscles, the pectoralis major, the external oblique aponeurosis, and serratus anterior. These are making the bed of the breast. So one mnemonic for all of you, the three muscles you can remember with the help of the mnemonic PES. PES. So what are these PES? P for sir pectoralis major, E for sir external oblique aponeurosis, S for serratus anterior. So these are the points which you must remember. Now we are going to see the structure of the breast. So catch this point. Sir, there is our, yes, you can observe the breast. Skin is there, and then conical projection nipple is here. Around this conical projection there will be the pigmented area known as areola. Fine. Now the breast is having the skin and then superficial fascia. Breast is located within the superficial fascia. MCQ. Here you will see the breast is having the abundant amount of the fat. This entire yellow color is showing the fat. So here is the too much amount of the fat as well as collagen in connective tissue. So you will say stroma. Fine, sir. So fat is there, connective tissue is there. So this is one type of the tissue. Another type of the tissue is glandular part. So can you see here is the presence of the lobe which is synthesizing the milk. So it is known as the lactiferous lobe. MCQ, how much amount, how many lobes are present? This is the your old NEET PG question. Remember 15 to 20 lobes are present in each breast. Okay. Now there is the synthesis of the milk within the alveoli and these all are stored within the one cavity. So this cavity is known as the sinus, as we all know. Whenever there is the term sinus, sinus means cavity. So this is our lactiferous sinus. So milk is stored here. Now from here, ducts are arising and they are reaching to the nipple. Yes. So the all lactiferous sinuses, they are opening within the our nipple. So these are simply known as the duct. Yes, sir. Lactiferous duct. Means you have to remember lobes are opening into the sinus. Sinuses are opening into the duct. Agree? Yes. These are lactiferous lobe, lactiferous sinus and lactiferous duct. Simple. Clinical integration. Yes. Anatomy is so elegant, so beautiful, just looking like a wow. If your anatomy is strong, you will catch that everything is very, 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 very easy. How? Sir, if there is the cancer of the our duct, then you will say ductal carcinoma. But if there is the cancerous proliferation of the lobe, then you will say lobular carcinoma. Yes, you will learn in your patho, in your surgery, in your medicine as well as obs-gynae, two types of the very important carcinoma: ductal carcinoma in situ, which you say DCIS, and lobular carcinoma in situ, LCIS. So just break the name and get the idea. मिर्जा गालिब कहते हैं सारे राज नाम में दफन रहते हैं. अगर कैंसर डक्ट से अराइज हो, डक्टल कार्सिनोमा इन situ. If the cancer is arising from the lobes, then lobular carcinoma in situ. So simple. Okay. Now catch this point. Here you will see the loose space. Yes, sir. That loose space I told you, that is our retro memory space. Yes, sir. Retro means behind, memory means breast. Okay. Now after that, can you see there is the presence of our, yes, the deep fascia of the pectoral region, pectoral fascia, and then there is the presence of the muscles like the pectoralis major, external oblique aponeurosis, and serratus anterior, which you can easily remember with the mnemonic PES. Okay. Now here you can observe for the proper support of the breast, for the proper shape of the breast, there is the presence of the few ligament. These ligaments are attached between the skin and then they are piercing the our holding the lobes and then attached to the pectoris major. Can you see? Yes, sir. These are attached to the our, yes, pectoral fascia. So these are our ligaments which are suspending the breast, which are holding the breast, which are giving proper shape to the breast. These are the suspensory ligament studied by the Cooper, so known as the suspensory ligament of Cooper. Important MCQ. Yes, we are going to draw this diagram. Also, you can observe the each lobe. How many lobes are there? Sir, 15 to 20 lobes. MCQ. Now, within the each lobe, can you see the unit of the milk synthesis, that is the alveoli, also you can say SE9. These are synthesizing the milk and these are coming stored within the our sinus. And now, due to the milk ejection reflex, during sucking by the baby, it is going to the our duct and getting ejected from the nipple and baby is sucking the milk. So this is the structure of the breast. Okay. So for your purpose, I am going to draw the diagrammatic presentation, especially for the first MBBS students. Try to understand. I am going to cut the our breast portion here. You are observing from the lateral side. So when you will observe from the lateral side, you will see the breast is having the skin, conical projection is nipple. Okay, sir. Fine. Now catch this point. There is the pigmented area, that is the areola around the nipple. Fine. Now catch this one, sir. This is our breast. We are looking from the lateral side. Yes, sir. Here at the deeper aspect, you will see, sir, there is the presence of the our muscles one by one. The breast is having the fat as well as fibrous connective tissue, which I am making with the yellow color. Okay. So there is the skin and the superficial fascia, which is having the fat and fibrous connective tissue. I had drawn with the yellow color. Yes. The pigmented area around the our nipple, sir, this is our areola. So these are our structures at the breast. Okay, now what I want to tell you, within the breast there is the presence of the lobes. So this is the our lobe. Now these lobes are synthesizing the milk and which is stored within the sinus, and this sinus is opening into the our duct. Yes, total how many lobes are present? Answer is, sir, 15 to 20. Lobe, sinus, and then duct. Simple diagrammatic presentation. Okay, fine, sir. Now, catch here, at the depth, there is the loose layer. So, this is the our loose layer over which the breast is moving freely. This is our retromammary space. Yes, sir. This pink color is the retromammary space. Okay. Now catch here, there is presence of the fascia. Yes, sir. There is a presence of the fascia that is around our pectoralis major muscle. So how this pectoralis major muscle is taking origin? Sir, here is the our clavicle. I am drawing the cross section of the clavicle. Below the clavicle there is a groove, that is the subclavian groove, within which you will see one muscle. Which muscle, sir? Definitely that is our, yes, subclavius muscle. You are looking from the lateral side, you are looking the clavicle, just below the clavicle subclavius muscle. Now you will observe the pectoralis major muscle is taking origin from the anterior surface of the our clavicle. So simple diagrammatic presentation, sir. This brown color structure is showing the pectoralis major muscle. Got the point? Okay. Now observe this one, sir. This is covered with the deep fascia. The deep fascia at the pectoral region, this is known as pectoral fascia. Okay, sir. So this is our pectoral fascia, the deep fascia of the pectoral region. Got the point? Now look here, sir. There is the presence of the our ligaments which are connecting the skin to the deep fascia. Yes, these are the suspensory ligament of the breast. Yes, these are the suspensory ligament of the breast. Very, very important structure. These are responsible for the proper support of the breast. Fine. What I want to tell you again, labeling the structure of the breast. So you can see, sir, here is our first layer. You can say skin. Then just below the skin, you will see the superficial fascia. Yes, fascia is nothing. That is the fat, and it is loaded with the connective tissue. So you will say the fatty stroma, connective tissue. Okay, that's why breast is soft in consistency. Okay, sir. Now here you can see the glandular compartment, the parenchyma. Yes, sir. These are the our glands. Also at the skin, you can observe there is a conical projection. This is nipple, and around the nipple you can see the pigmented area which is known as areola. Agree? Fine. Now look here, I told you there is the presence of one loose space just behind the breast over which the breast moves freely. That is retromammary space. Remember the clinical point, when you perform the mastectomy operation, at that time we give the incision in this plane and we remove the breast. So this is the question. This retromammary space is very important for the surgery, sir. It is the surgical plane for mastectomy operation, the beautiful integration of the anatomy with the surgery. Okay, sir. Now few more points, try to understand. Sir, deep to the our these all the structure. Yes, sir. Retromemory space, I told you. Here is the our fascia. Which fascia? The deep fascia, pectoral fascia, and this muscle is nothing. This is our pectoralis, big muscle. That's why major. Okay. Now catch this point, sir. The bed of the breast is formed by, definitely you can say, retromammary space. You can see the pectoral fascia, then pes muscle. So bed of the breast, these are formed by three muscles, but you can say the sequence bed of the breast, sir. First is our retromammary space, then second is pectoral fascia, then third you can say the PES muscles. Yes, pectoris major, external oblique aponeurosis, and serratus anterior. So this are the our different structures making the bed of the breast. Okay, sir. Now look for the our next concept, sir. Here is our few more points. This is our clavicle. So just below the clavicle muscle present, that is sub means below the clavicle, that's why subclavius you will say. Now at the depth of the our pectoralis major, you will see one another muscle we had seen in our pectoral region area. Sir, this is small muscle below the pectoralis major. So you will say, sir, it is our, yes, pectoralis small, that's why minor. Okay, now concentrate. There is the presence of one fascia making with the green color, which is located in between the clavicle and pectoralis minor. Let's give the name, sir. It is known as clavi. Yes, in between the pectoralis minor. That's why pectoris, clavipectoral. It is our clavipectoral. It is the just condensation of the collagen and the fat. So you will say, sir, fascia. So this is nothing. It is our clavipectoral fascia. Very, very important structure. Yes, it is pierced by four structures. Very, very important question. Remember, it is pierced by the four structures. What are the different four structures? Remember, one artery, one vein, one nerve, and one lymphatic. Yes, one artery, one nerve, yes, one vein, one nerve, and one lymphatic. So everything is one. Which artery is present at this clavipectoral fascia? Yes, it is between clavicle and pectoris minor. So here is our one artery, thoraco acromion artery. I will teach you in the artery part. One vein. Here is the one vein which is running from the our preaxial border, and then it is running in the deltopectoral groove. That is our cephalic vein. It pierces the clavipectoral fascia and then opens into the our subclavian vein. Also, you can say the axillary vein. Okay. Now the one nerve. Here is the our lateral pectoral nerve. Very important question. And remember, the deep lymphatics are present. Only with the lymphatic you can remember, na? So these are the points, lymphatics. Okay, otherwise one mnemonic also you can remember the four structures. Yes, TALC, talc. So TA for thoracoacromion artery. There are the two L, lateral pectoral nerve, and simply the lymphatic, and C is your cephalic vein. It is very, very, very important. Previously asked question. No excuse. The structures piercing the clavipectoral fascia. Okay, sir. So another few more question. This clavipectoral fascia, it is enclosing the two muscles. Yes, sir. The upper end of the clavipectoral fascia, it splits and encloses the subclavius muscle, MCQ, and the lower end, it splits and covers the pectoralis minor muscle. 2 MCQs again for all of you. Now try to understand further. I'm giving the nomenclature. Sir, it is splitting the subclavius and pectoralis minor muscles. Okay. Now look here. The lower part again it is fusing together and progressing forward, and it is making one concave surface. Yes, it is running towards the axilla, and then it is fusing to the our pectoral fascia. Okay, so can you see diagrammatic presentation? There is a one concavity. Try to understand. Here is the clavicle. Pectoris minor is here. This fascia is running from the clavicle towards the enclosing the pectoris minor. Then it is reaching to the axilla, and axilla is concave in shape. Yes, sir. So this is our concavity. This is our axilla portion. So that continuation of clavipectoral fascia is nothing. This is known as suspensory ligament of axilla. Yes, catch this point. This is suspensory ligament of axilla. It is pulling. It is pulling. That's why the axilla is concave in shape. Suppose due to any infection or any problem, any injury, this suspensory ligament of axilla is getting ruptured, broken. In that situation, the axilla skin will get loose. One beautiful concept from the anatomy. Okay. Yes. Now catch one more question which had been asked very earlier. Suspensory ligament of axilla is modification of what? Answer is our clavipectoral fascia. But you will observe one more MCQ. The upper part of our clavipectoral fascia, it is getting thickened in between the our, yes, coracoid process and the first rib. So this thickening of the clavipectoral fascia, upper thickening, okay, lower part continuation is making the suspensory ligament of axilla, MCQ. But the upper thickening of the clavipectoral fascia, sir, it is in between the first rib. That's why you will say costo and the coracoid process. That's why coracoid ligament. Okay, sir. So this is the another modification. What you have to remember? The four structures pierced by the clavipectoral fascia. Okay, sir. But also the clavipectoral fascia, magic of two, it encloses two muscles. It forms two ligament modification. What are the different two muscles? You can remember, sir. These are our subclavius, and another one is your pectoralis minor. Okay, now what are the different two ligaments? So you can remember suspensory ligament of axilla, and another ligament was our costocoracoid ligament. Do you remember costocoracoid ligament in between? Just break the name and think about it. It is in between costo means rib, and coracoid, simply the coracoid process. Okay, so this is the magic of two for the our, yes, you can remember magic of two for the clavipectoral fascia. इससे बाहर का कोई क्वेश्चन नहीं आएगा. वेरी वेरी इंपॉर्टेंट टॉपिक रिलेटेड टू द ब्रेस्ट एज वेल एज द clavipectoral fascia. Now look for this our more things. I told you everything. Just one revision with this previously made notes for all of you. Skin, sir, in the skin, nipple and areola, they are seen. But one very important question: Montgomery tubercle. Remember, around the nipple there is the presence of the modified sebaceous gland around the, better to say, areola. Modified sebaceous gland around the areola, known as Montgomery tubercle. Remember, the breast is modified sweat gland, MCQ, but Montgomery tubercle, these are the modified sebaceous, modified oily gland. Now look, when the baby is sucking the milk, okay sir, at that time continue wetness around the nipple, fine. So modified sebaceous gland, Montgomery tubercle, they are releasing the oily secretion, and this is preventing the crackling of the nipple. Yes, we apply the Vaseline, we apply the lip balm, we apply the oil in our winter season, rainy season. So in the similar way, this oily secretion from the Montgomery tubercle, sebaceous secretion, yes, These are preventing the crackling of the nipple. Okay, sir. So this is the preventive mechanism created by the God. Now look, parenchyma. Here we get glands. That's why remember, yes, in histology, I will teach you the gland means adeno. Yes, sir, it is our adeno. Total how many glands are present? Sir, 15 to 20 lobes of the gland, MCQ. Then they are draining into the our lactiferous sinus. Then it is reaching into the lactiferous duct, and then it is opening into the nipple. Again, one simple diagrammatic presentation. Sir, here is the presence of lactiferous lobes. MCQ, 15 to 20 lobes are there. These are opening into the sinus, lactiferous sinus, and then it is opening into the our lactiferous duct. So these are the part of the parenchyma. Breast is having the two types of the tissue: fat, connective tissue, stroma. Okay, sir. And another is the parenchyma, in which gland is present. So what you can remember, sir, we are talking about the stroma, sir, supporting framework of the gland. Yes, sir, which is having the fibrous connective tissue and the fat. For your UG exams, you can do, and if your UG first MBBS is strong, then definitely you will crack INICT, NEET, PG, USMLE, PLAB, any kind of the exam. So fibrous connective tissue, it makes septa partition, yes, which is known as the suspensory ligament of the Cooper. Fine. But about the fat, main bulk of the breast is the fat. Yes, that's why the breast is soft in consistency. Now try to understand, it is situated everywhere in the breast except below the nipple and areola. That's why just below the nipple and areola, the area is not too much soft, it is little bit firm. Okay, now look here, according to the NMC, yes, we have to look for the competency based medical education. So remember, we are doing the anatomy, biochemistry, pathology, surgery, obs, gynae, integration. Yes, we will see the breast carcinoma. In the breast carcinoma, there is the abnormal mass formation. Yes, breast carcinoma, cancer. So there is a formation of the mass, and this mass is obstructing the lymphatic route. Yes, sir, lymphatic roots, the lymph flow, it is obstructed. So there is the abnormal hemodynamic changes. Yes, fluid is not drained from the breast. In that situation, according to the pathology, hemodynamic changes, yes, when the fluid is getting accumulated, there is the beginning of the inflammation. This is the your pathology integration. Now, if there is an inflammation, means rubor, tumor, dolor, calor, functionalism. So these inflammation are leading to the release of the different chemical mediators of the inflammation, among which there is the fibroblast growth factor, FGF is one of them. Pathology integration. Yes, this is causing the establishment of the fibroblast, and this fibroblast is responsible for what? Pathology says collagen formation. So more fibroblast, more collagen synthesis. Now, more collagen, sir, the more abnormal excessive deposition of the collagen is known as fibrosis. Okay, so in case of the fibrosis, there is a shrinkage of the tissue. So if it is involving the gland, so in that situation, there is the pulling of the gland. So catch this point. If there is the pulling of the gland, yes, sir, if there is the fibrosis of the gland, then it will pull the tissue inside. Yes, it will pull the portion inside, because there is the our contraction, fibrosis, collagen. So due to it, the nipple, it will go, yes, inside. So this is nothing. This is the our inverted nipple or retracted nipple. So due to the fibrosis of the gland, there is the retraction of the nipple. Very important sign for the breast carcinoma. In case of the breast carcinoma, you will see the retracted nipple. And in the similar way, if there is the fibrosis, if there is the fibrosis of the our suspensory ligament, sir, it is attached to the skin. So what you will see, sir, there is the our skin portion, it will go inside, it will go inside. Yes, it will go inside, it will go inside. So it is resulting into the dimpling of the skin. Hope you all are catching the point I'm going to show you. Yes, these all are the clinical points you will see better in your surgery final year. But just one integration, first MBBS dear students, please listen this all the things carefully, and you can forget. Okay, but when you will go for the clinical, then you will say, okay, these all the things Shrikant sir taught in the anatomy portion. Okay, so what I want to tell you, sir, this is the breast, but whenever you are looking, that nipple is going inside, it is not going outside. Normally, you will see everted nipple, but if you are looking inside a nipple, retracted nipple, yes, can you see this position? Sir, this nipple areola, they are normal, but here they are retracted. So this is one of the common sign for the breast carcinoma, very important. Now, look for this one. Sir, this is our inverted nipple. You can see easily, this is the our indicator of the breast carcinoma. Very important integration with the surgery. Can you see there is the presence of the suspensory ligament of the Cooper? So if they are fibrosed, then they will pull inside and there is the dimpling over the skin. Can you compare here? Yes, sir, there is the dimpling over the skin. So again, this is indicating the breast carcinoma. Also, you can see there is a retraction of the nipple. So this dimpling of the skin due to the suspensory ligament of the Cooper and this retraction of the nipple is due to the, remember, sir, it is due to our fibrosis of the glands. Hope you all are getting the points. Now look for the next. Sir, we are going to look for the arterial supply. So here's the one diagrammatic presentation. Remember, the breast is here. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. So here is the presence of the artery. Which artery is flowing here? Sir, this is our, yes, subclavian artery, which is continuing as the axillary artery. Then it will continue as the brachial artery. You will see in the our arterial portion. Okay. Now, later I will teach you that subclavian artery, it is having the branches. Very important. Later I will teach you. Now, yes, it is having the first part, second part, third part. And the branches you can remember with the mnemonic VITCD, vitamin CD. So, later we will see the subclavian artery is having the V for vertebral artery, I for internal mammillary artery, T for thyrocervical trunk, C for costocervical trunk, and D for dorsal scapular artery. Later in the clinical part, I will teach you this vertebral artery. Yes, it is giving the one branch, that is the posterior inferior cerebral artery. So if this artery is involved, there is the our pica syndrome, which is also known as the lateral medullary syndrome, also known as the Wallenberg syndrome for the NEET PG. Very important question. The internal mammillary artery, sir, it is supplying the our, yes, breast from the inner side. It is the best artery for the coronary artery bypass grafting. Yes, it is another important MCQ. More things I will tell you later. But right now, sir, the continuation of the subclavian artery is known as axillary artery. So here is the axillary artery. I will teach you later the branches of the axillary artery. There are the three parts of the axillary artery. First part, second part, third part. First part is giving the one branch, second part is giving the second branch, third part is giving the third branch. Yes, go for the arterial system video in our app. You will get all the thing. Okay, so here the first part is giving the one branch which is supplying the thorax from the superior side. What should be the name? Superior thoracic artery. Break the name, get the idea. It is superiorly in the thorax. Then another artery is close to the acromion process. This artery is near to the our acromion process. So you will say acromiothoracic artery. And then another artery is running at the thorax laterally. So laterally, that's why lateral. In the thorax, that's a thoracic artery, lateral thoracic artery. In short and sweet way, you can remember the nickname. Sir, these are the our arteries: Sata, Ata, and Lata. Superior thoracic artery, acromiothoracic artery, and then lateral thoracic artery. These are supplying the breast. Also, the internal mammillary artery, I told you the branch of the subclavian artery, it is supplying the breast from the inner side. Yes, these are the our perforating branches of the internal mammillary artery. Also, you can say internal thoracic artery. Now, catch the posterior intercostal artery. They are supplying the thorax from the behind. In thorax, we will see these are giving the perforating branches which are supplying the breast from the lateral side. So, short and sweet way, you can remember the artery supply of the breast with one mnemonic SALI, SALI. Yes, your mnemonic is SALI, SALI. The branches are, yes, superior thoracic artery, acromiothoracic artery, lateral thoracic artery, and internal thoracic artery. Also, you can say the internal mammillary artery. So your funny mnemonic is SALI. Jija Sali. Sali is your mnemonic. Why it is important, beta? Because of the breast cancer surgery. You have to ligate these arteries for the breast surgery to cause minimum bleeding. that surgeon is best who is doing less bleeding. And how you can do the less bleeding if you're proper aware about the arteries. So you have to ligate these arteries and you have to perform this surgery. That's why it is important. Now we are going to look for the our lymphatic drainage of the breast. Catch this point, these notes. Yes, lymph nodes, very important topic, because the breast cancer spread through the lymphatic route. Yes, lymph node, lymphatic drainage, two heading, lymph node and lymphatic vessels, simply which are known as the lymphatics also. Try to understand. Suppose this is the cell. Yes, the arteries are supplying and the veins are draining the blood. Yes, sir. Suppose these are the our, yes, veins. But when the blood is coming, there is a filtration of the fluid. So this filtered fluid, which is not drained by the vein, they are our extracellular fluid, you can say. Yes, these are our lymph. These are drained by the channels, tubular channels, which are parallel to the vein, known as the lymphatics. Within the root of the lymphatics, you will see the nodular structure. These are our lymph node. Okay, sir. So ultimately, through the lymphatic vessels, it is draining again into the our main circulation. Then it reaches to the heart. Okay. Now see the important question. We had seen the concept of the lymphatic lymph node. Now this is the your very important question for the surgery as well as first MBBS exam. The short notes are asked. Okay, lymph nodes of the breast you can divide under the three category. First, axillary lymph node. 75% of the breast lymphatics is drained into the axillary lymph node. Next, there is our internal mammillary or internal thoracic lymph node, which is located along our internal mammillary vessels. 20% is drained here. Yes, it is along the internal mammillary artery or vein, you can say. Now, only few lymph nodes, 5% are there. Yes, there is a supraclavicular lymph node, which is above the clavicle. Deltopectoral lymph node, yes, in the deltopectoral group where the cephalic vein was there. That's why it is also known as the cephalic lymph node. Yes, posterior intercostal lymph node, it is located on the back side, posterior intercostal part. Okay, and also the subdiaphragmatic, which is below the diaphragm, as well as the subperitoneal, yes, which is below the peritoneum in the abdomen. So these are participating in the formation of the lymphatic plexus. Very few part of the breast is drained here, but the major is our axillary lymph node. So this is important and it is very easy. I will teach you the boundaries of the axilla. Armpit, entry wall, posterior wall, lateral side humerus, and medial side is chest wall. So along the each wall there is the lymph node. So anterior axillary lymph node, then posterior axillary lymph node, then you will say the lateral side axillary lymph node, then you will say medial side axillary lymph node. Now this all the lymphatic they drain into the central part of the axilla, central axillary lymph node. Now the central axillary lymph node, they are draining above the clavicle. Yes, they are draining at the apex of the axilla, apical axillary lymph node, and from here it is reaching to the supraclavicular lymph node. So these are the points you have to revise it again and again. This is the table. I told you it is useful for the surgery, NEET PG, INI, CT, FMG exams, as well as for your short note in your university exams. Okay, beta? Now, look here, the diagrammatic presentation for the lymphatic drainage. Can you see? Here I had made the breast for all of you. Okay, sir. Axillary tail of the spans. Fine. This is the our nipple and pigmented area areola. Okay, sir. Now catch this point. The majority is drained into the axillary lymph node. What are the different lymph node? Yes, there is the group of the lymph node which is present anterior wall. Along the entry wall, entry axillary lymph node. Now along the posterior axillary lymph node, along the posterior axillary fold, posterior axillary lymph node. On the lateral side, there is a humerus in the arm. So this is the group of the lymph node, lateral axillary lymph node, and another on the chest wall. So this is our midline portion in between the anterior and posterior axillary lymph node. There is the our medial axillary lymph node. These all are draining into the central part, central axillary lymph node. And then these are draining into the apex portion of the axilla, that is the apical axillary lymph node, and then it is draining into the above the clavicle, supraclavicular lymph node. Yes. How the lymphatic of the breast is drained? Again, I am revising, sir. These our lateral part, especially the upper lateral and lower lateral quadrant, they are draining into the axillary lymph node. Then it is draining into the central axillary lymph node. Then central axillary lymph node, it is draining into the apical lymph node. Then apical lymph node is draining into the supraclavicular lymph node. Simple. Okay. Anatomy is so elegant, so beautiful, just looking like a wow. Okay. While the medial part, it is draining, it is close to the internal mammillary or internal thoracic lymph node. So it is draining at this particular area. So simple. Okay, so this lymphatic drainage you must remember. Now I am telling you the few lines about the lymphatic vessels and the lymphatic for the PUD orange appearance. See here, there are the two types of the lymphatic: superficial lymphatic within the superficial fascia, deep lymphatic below the deep fascia. Now the superficial lymphatic, it drains skin over the breast except nipple and areola. So this is the MCQ. The breast is superficial fascia structure. So it is drained by the superficial lymphatic. Except, and whenever there is the exception, the MCQs are asked from there. Except answer is nipple and areola. Yes. Now try to understand. They drain radially. Yes. To the nearby lymph node. Can you see? Sir, this is the breast. Here is a nipple and the areola part. So the lymphatics, they are draining radially. That's why in surgery you will see whenever you have to give incision in the breast for the breast abscess, for the pus collection or anything, always give the incision radially to avoid the damage to the lymphatic drainage. What you have to remember, sir, surgery, sir, surgical incision in the breast, they are given radially, not transversally, not circumscribed, okay, to avoid damage to the lymphatic vessels. Beautiful integration, conceptual brainstorming, integration of the anatomy and the surgery. Okay, now look here, sir. Deep lymphatic, they drain parenchyma of the breast, deeper part, also the nipple and areola. Yes. So these are drained by what? These are drained by the deep lymphatics of the one anatomist who studied about it, SAPI. Yes. So your answer is the drained by the subaerial plexus of the SAPI. These are present below the areola. That's why subaerial plexus of the SAPI. So nipple and areola, they are drained by, remember, deep lymphatic, subaerial plexus of the SAPI. Okay, sir. Now look one more diagrammatic presentation. This is the transverse section of the thorax. You can observe, sir, this is our vertebra. Yes, sir, it is the vertebra. Means you are looking from the above. Sir, here is the sternum. This is the posterior chest wall and here is our anterior chest wall. Okay, so this is the location of the breast. Yes. Look here, there is the our lymph node on the thorax anteriorly. So you will say anterior thoracic lymph node. This is nothing. This is the internal mammillary lymph node. Also, you can say, sir, internal thoracic vessels are there. So breast medial portion, it is draining into the our internal thoracic lymph node. Internal thoracic lymph node. Also, you can say the internal mammillary lymph node. These are located along the internal thoracic vessels. Okay, sir. But also you can see the lateral part. Yes, it is draining on the medial part as well as along the posterior intercostal vessels. It is going to the back side. Here is the presence of the intercostal lymph node. Inter means in between, costal means rib. So in between the two ribs, there is the presence of the lymph node. So this is our intercostal lymph node. It is located on the posterior side. So better to say posterior intercostal lymph node. Yes, these lymphatics are draining along the posterior intercostal vessels. Okay, so these are our lymphatics, the tubular channel which are draining the lymphatics to the different lymph nodes. Okay, sir. Now look for the next. I told you already the deep lymphatic, but one diagrammatic presentation, sir. This is the our nipple and areola. So just below the nipple and areola, there is a presence of the subaerial plexus of the SAPI. It is draining the deep parenchyma part. Yes, the lymphatics, they are draining through the foramen of Langer and it is reaching, piercing the deep fascia and reaching to the anterior axillary lymph node. Okay, sir. Diagrammatic presentation. for the subaerial plexus of the sapi. Sir, subaerial plexus of the sapi, yes, it is draining the parenchyma, nipple and areola, and sending the lymph into the anterior-axillary lymph node group. Okay, so remember this point. Few important points regarding the lymphatic drainage important for the surgery and patho. Most important lymph node, MCQ, 75% drained into the axillary lymph node. So that's why in surgery, palpation of the anterior axillary, posterior axillary, medial, lateral, central, apical, supraclavicular lymph node, they are very important. Surgery, clinical. Yes, 20% internal mammillary lymph node and 5% posterior intercostal and other lymph node. MCQ, axillary lymph node. Remember, the axillary lymph node, they are draining into the central axillary, then reaching to the apical axillary lymph node, then it is reaching into the supraclavicular lymph node. Just simple notes. Internal mammillary lymph node, they are draining the inner half of the breast as well as the outer half of the breast both. Next point, the subaerial plexus of the sapi, yes, it drains into the anterior, or also you can say the pectoral lymph node group. The deep part of the breast parenchyma, it is draining into the deep lymphatic, yes, it is piercing the clavipectoral fascia. Now lymphatic from the lower and inner quadrant of the breast, yes, they are crossing the costal margin and also piercing the anterior abdominal wall, and they are joining the subdiaphragmatic area, the metastasis part. Yes, it is piercing the, it is joining the subdiaphragm, it is going downside, and it is reaching into the our peritoneum also. So it is spreading to the subdiaphragmatic area. Yes, subperitoneal lymphatic plexus. Yes, try to understand one diagrammatic presentation. Sir, it is the breast. Sir, the lymphatics from the lower part as well as upper part, they are crossing the diaphragm. Suppose this is our diaphragmatic area, and below the diaphragm, within the subdiaphragmatic lymph node, it is reaching. That's why, in case of the breast cancer, when there is a cancer through the lymphatic route, it is reaching below the diaphragm and it is causing the cancer of the abdominal structure also, like the ovarian tumor, that is a Krukenberger tumor. MCQ. Now look, the anterior and the central group of the lymph node, these are most commonly involved. Anterior lymph node and the central group of the lymph node, they are most commonly involved in the breast cancer. So the lymphatic route is very, very important. Clavipectoral fascia. I told you there is the one fascia in between the clavicle and the pectoralis minor. Yes, this is the clavipectoral fascia. I told you it is pierced by the four structure. Yes, one artery, thoracoacromial artery, one vein, cephalic vein, one nerve, that is our lateral pectoral nerve, and our deep lymphatics. Okay, sir. This is the our suspensory ligament of the axilla, and the upper thickening is the costocoracoid ligament. It is enclosing the two muscle. Yes, upper is subclavius and the lower is pectoralis minor. Okay, you can see another diagrammatic presentation. Sir, this is our clavicle and here is the pectoralis minor muscle. This is the pectoralis minor muscle. So there is presence of the fascia in between the clavicle and the pectoralis minor muscle. This is nothing. This is the our clavipectoral fascia, which is pierced by the four structure, the cephalic vein, the thoracoacromial artery, the lateral pectoral nerve, as well as the deep lymphatic. Okay. Now look for the next. This is the same thing, diagrammatic presentation for all of you. Again, here is our clavipectoral fascia, which is pierced by the one artery, one vein, one nerve, and lymphatic group. Okay. Yes, this is the your notes. See here, deep part of the breast parenchyma, they are drained by the deep lymphatics, pierces the pectoral fascia, and it pierces the pectoris major also. Then it is piercing the clavipectoral fascia, and then it is draining into the apical lymph node. Here is the pathway. See here, sir, the deep lymphatic, it is draining the deep part, it is piercing the pectoral fascia, then pectoris major muscle, then it is piercing the clavipectoral fascia. So this is the pathway. It will be useful to understand the pathogenesis of the breast carcinoma and different clinical features. Now look, sir, now we are entering for the clinical, which will be better taught in the pathology, surgery, different clinical subject. But one beautiful integration here. Inflammation of the breast is known as the mastitis. Itis means inflammation, and whenever there is a inflammation means rubor, tumor, dolor, calor, functionalisa. Yes, this mastitis may be two types: acute, sudden and severe, and the chronic. Now from here your surgery will start. Now this is the abnormal, excessive, unrestricted, uncontrolled growth of the tissue that is known as the tumor. Sir, there are the two types of the tumor: biochemistry integration, a small tumor, less dangerous, benign, and the more dangerous is the malignant, which is showing the property of the metastasis and invasion. Okay, so the fibrous connective tissue is proliferating and the glandular tissue is proliferating. Yes, this is the benign tumor. Yes sir, it is the benign tumor, fibroadenoma, which is also known as mouse of breast. Very important, because it is located within the superficial fascia. There is a formation of the knot. Okay, yes, mass lump which is freely mobile. It is not invading deep side, so it is freely mobile. So when you will hold this one, it will move here, there in the breast. So that's why it is known as the mouse of the breast surgery. But the invasive one, yes sir, the malignant is our breast carcinoma. Okay. Then we are going to look for the congenital anomaly of the breast also. Amastia. A means absence. Mashed word is indicating the breast. So absence of the breast is known as amastia. And when there is a presence of the multiple breast, more than pair, then it is the polymastia. When there is the absence of the nipple, thalia. Thalia word is indicating the nipple. So when there is the absence of the nipple, you will say athalia. And when there is a presence of the multiple nipple, then it is a polythalia. Okay. So one by one, try to understand. Milk line of the shoulders. When you will see the lower animal, you will see the multiple nipple, multiple breast on the ventral surface. That's why this is the one common phenomena. You will see the doggy, cats, they are having the many babies and they are sucking the milk simultaneously because they are having the multiple breast. Yes, in the human also, try to understand in the similar way. There is the ectodermal thickening of the skin and they are preparing one line. This was studied by the Schultz. That's why it is known as the milk line of the Schultz. Okay, fine. Now, what you have to remember, this milk line, along this milk line, there's a development of the breast in the animal. Okay, so animal, they are having the breast at the axillary part, maybe at the pectoral part, yes, at the abdominal part, breast is there, and in the inguinal part. But in human, during the development, all this breast disappeared, only persisting the pectoral region. So this is the developmental correlation. What I want to tell you in the flowchart form, sir, breast develops from ectodermal thickening, MCQ, from axilla to the groin. Only pectoral region ectodermal thickening persists, so it is converting into the mammillary pit. Yes, from this pit, secondary bud, they are arising. 15 to 20 buds are there which are growing from floor of the pit. Okay, sir. Now what is happening? Later nipple is everted from the pit side. Then secondary buds divide and subdivide to form the lobes. 15 to 20 lobes are there. Now earlier lobes are solid, but later there is a canalization. So you will see in the pedia the development of the breast part. Okay, but this is a summary of that one. So what I want to tell you, the breast is present from the axilla up to the inguinal region, but in human only the pectoral region breast they are properly developing. Okay, sir. So now see congenital abnormalities of the breast. Suppose this milk line of the Schultz is not developing, so patient is not presenting with the any breast, so no breast, absence of the breast, so you will say a mastia. Yes, there is the no breast. Now can you see, suppose there is a presence of the breast at the pectoral region, also the abdominal region, also you can see at the inguinal part also. So multiple breast is there, that's why you will say polymastia. Sometimes what happens, the breast is not developing, only the nipples are developing. So you will see very common phenomena, that is the accessory nipple also. Okay, only nipple will develop. Can you see one another? But it is not a congenital condition. Yes, the male, they are having the hormonal imbalance and they are presenting with the breast. So this is our gynecomastia due to the hormones imbalance. It is not the congenital. No? Also, there are the many drugs which causes the gynecomastia. You will learn in the pharma and the different subject like the spironolactone. This all many drugs which are causing the our gynecomastia. Okay, sir. Now, can you see this situation? Yes, sir. Here you can see the multiple nipple. So, multiple nipple, accessory nipple are present. Then you will say the polythalia, the accessory nipple. Getting the point? So, these are the different situation. Now, catch this our little integration with the histology. Yes, histology of the breast is not important, but the fibroadenoma is important. Can you see? Normally in the breast, sir, there is the presence of the gland and the connective tissue. Connective tissue, it is having the fat adipose tissue. Yes, and our too much amount of the collagen, this all. But within this adipose tissue and the collagen, there is the presence of our gland. Okay, sir, glands are present and these are having the duct also. So this is your glandular part, remaining are our connective tissue part. Can you see here? That was a schematic diagram presentation. This is the real image. So you will see there is a presence of the our glands as well as the duct, which are lined by the cuboidal epithelium. And this remaining portion, these are your, yes, collagen connective tissue, supporting tissue. But when there is the our fibroadenoma, break the name and get the idea. Fibro plus adeno plus oma. Sir, fibro means excessive deposition of the collagen. Adeno means increase accumulation, increase proliferation of the glands. And oma means tumor. It is the most common benign tumor of the breast, mouse of the breast. So the fibrous connective tissue is proliferating as well as glands are proliferating. Because in this situation, the fibrous connective tissue is too much proliferating. That's why there is a slitting. This is the important word for the pathology integration. Slitting of the, yes sir, there is the slitting of our ducts. So whenever any patient is coming, there is the mass in the breast, female patient commonly, which is freely mobile. You are taking the biopsy and the ducts are showing the slitting, narrow, not rounded. Okay, so this slitting of the duct, definitely your diagnosis is going towards the fibroadenoma. Okay, now look for the our few more correlation. Breast cancer, this is the surgery part. So you will see, sir, there is a tumor. Two types of the tumor, benign and malignant. For the benign, we use the term oma. This is your biochemistry, surgery, medicine integration. Malignant, again two types, pathology, carcinoma, when the tumor is spreading by the lymphatic route, then you will use the term carcinoma. Yes, we are using the term breast carcinoma. Sarcoma, another malignant tumor is sarcoma. Yes, when the tumor spreads via the blood, hematogenous route, then you will use the term sarcoma. But never will listen the breast sarcoma word. Yes, what you have to remember, the breast tumor, malignant tumor, it spreads via the lymphatic route. That's why in your exam, the lymphatic drainage of the breast is asked because of this breast carcinoma. No, there is the our hematogenous spread. So breast sarcoma word is not existing. Now see here, usually not. Sometimes exception is always there. Okay, sometimes the tumor can spread via the our, yes, carcinoma. The lymphatic route is spread along with that. Sometimes the hematogenous spread may be shown. Now breast tumor shows lymphatic spread. That's why breast carcinoma. This is the very frequently asked question in the different time. Okay, in university exam, always alternative year you will see the breast lymphatic drainage question, and in your part completion test in your sessional exam, always you will see one question from the breast or it's a lymphatic drainage. So remember, lymph nodes, lymphatics of the breast, they are very important because of the breast carcinoma. Now look, the breast cancer. You will see the different kind of the classification. I told you right now, breast cancer, sir, benign breast tumor, you have to study in surgery. Fibroadenoma, which is also known as the mouse of the breast, you have to learn about the phyllodes tumor, and you have to look for the intraductal papilloma. These are the benign tumor, while the malignant breast tumor, you will see non-invasive. They are located in their own place. That's why in situ carcinoma. These are again two types of intraductal carcinoma and lobular carcinoma in situ. While the tumor which is spreading away, so you will say invasive, ये invade कर रहा है, it is invading to the distant place. So invasive duct carcinoma, invasive lobular carcinoma, yes, a medullary carcinoma. You will learn the colloid or mucinous carcinoma. You will learn the papillary carcinoma, tubular carcinoma, adenoid cystic carcinoma, secretory carcinoma, inflammatory carcinoma, and the carcinoma with metaplasia in your surgery and the pathology. So, on the basis of the anatomy, all the subjects will build up. Look here, the few more integration, pure D orange appearance. Very, very, very important question. Okay, so catch this point, sir. This is our orange. What happens in case of the breast cancer? The skin of the breast is also changing just like the our skin of the orange. Similarity. So this is known as the POD orange appearance. Okay. I told you there may be the retraction of the nipple. There is the presence of the dimpling of the skin. But right now we are looking the POD orange appearance for the breast carcinoma. Yes, sir. Why it is happening? Because of there is a formation of the mass, and it will block the subdermal. Below the skin there are the lymphatic. So the lymphatic drainage is not there. There is the inflammation, and in case of the inflammation there is a rubor, tumor, dolor, calor. So rubor means redness. So there is a redness of the skin. So skin is appearing reddish or orangish. Okay, and there is a suspensory ligament of the Cooper. They are pulling inside. So there is a swelling and suspensory ligament of the our Cooper. They are pulling inside. So at the site of the attachment of the suspensory ligament of the Cooper, this portion will show the small dots. So that's why the skin is appearing just like the orange. So this is the very important finding. Yes, signs of the breast cancer. So definitely cancer means mass. You will see the mass. Also, there may be the abnormal kind of the nipple discharge. You will see the serous discharge, the mucinous discharge. You will see the pus discharge. You will see the blood discharge, serosanguinous discharge. You will learn in the surgery. There may be the presence of the dimpling due to the pulling of the suspensory ligament of the Cooper, due to the fibrosis of the suspensory ligament of the Cooper. Breast or nipple pain. Yes, pain may be there. Nipple retraction or inversion due to the fibrosis of the lobes, lactiferous lobes, and there is the inflammation, redness may be there. Yes, changes to the skin texture, lymph node changes, and the swelling. So these are the important findings. If any female is having such kind of the presentation in the breast, get alert. Breast carcinoma may be there, because the breast cancer is most common cancer in the female in the world. Very important. Okay, that's why the government, they are promoting the self examination, breast self examination. So you will learn these steps in the your, yes, surgery as well as community medicine. Okay, so this is our social awareness. Remember, female have to stand in front of the mirror, and in front of the mirror, yes, hold the hand upside and then examine the armpit. Yes, because there is the presence of the lymph node. If there is a breast cancer, there is a chances of the enlargement of the lymph node. That's why. And then up and down, we have to move the hand, we have to feel the lump. Then circles and wedges, we have to observe circular manner, we have to move the hand. Up and down, we have to move over the breast by elevating the hand, and then circular manner, we have to move the hand over the breast, and then we have to squeeze the nipple, we have to feel if any mass is there, and also the same things we have to perform on the bed. Okay, so this is the breast self examination, very important. Okay, now metastasis, cancer, they are characterized by the invasion and the metastasis. Remember better, the breast cancer, yes, it can spread to the internal mammillary lymph node, and then it can involve the opposite breast also. Yes, it can go to the our axillary pectoral lymph node, then central group, then yes, apical, and then supraclavicular lymph node. It can spread, it can involve the bone like the humerus. Yes, it spreads to the our vertebra. That's why one more thing, very important, when you will go for the surgery, the doctor, the resident doctor, the HOD, they will ask about the history of the backache. Yes, in case of the breast carcinoma, there is one common symptom, backache, पीठ दर्द होता है. Why? Because the breast cancer, they are spreading to the our vertebral column. Now try to understand, these are involving the ribs also, involving the sternum also. Yes, it is spreading below the diaphragm, subdiaphragmatic lymph node. It can cause the liver carcinoma. Yes, it is involving the femur. Yes, it is reaching to the our ovary also. So you will learn about the Krukenberg tumor. In case of the stomach carcinoma, in case of the breast carcinoma, it is crossing the subperitoneal and it can cause the ovarian cancer also. Breast cancer may be associated with the ovarian cancer. Also remember, yes, this is the vertebral venous plexus. The breast carcinoma, it spreads via the vertebral space, vertebral venous plexus of bat sun. Yes, Batman ka beta. You can remember in this way. Batman son, bat son, vertebral venous plexus. Yes, the breast carcinoma spreads through the our vertebral venous plexus. Entire it will involve the our vertebral column and it will cause the backache. पीठ दर्द की शिकायत करेगी. Don't forget to take the history of the backache in case of the breast carcinoma. Now look here further. The radiology integration. In radiology, you will see the mammography. Yes, graphy means visualization. Yes, the mammo means breast. So you will see in the breast, you have to put the breast transversely and the rays will pass and you are doing the examination. Can you see? There is the our one dense area here, but it may be normal also. But when after 1 year you are observing the film, you can compare here. Sir, here is the density increasing. So this is our cancer detection. Okay, so you will better learn in your radiology part. This is the mammography. One fact you have to remember, that in menopause, after menopause, what is happening? Estrogen, progesterone, these all the levels are falling. So less estrogen and decreased level of the estrogen, it leads to the breast carcinoma. Also remember, the cancer, what is the permanent treatment? You have to cut, you have to remove. Means you have to do ectomy. Whenever there is a ectomy means cut and remove. Tommy means cutting. Anatomy, just cutting. And whenever there is a term stomy, yes, what I want to tell you, Tommy means cut, stomy means opening creation, and here is the ectomy, means you have to cut and you have to remove, that is the ectomy. So breast cutting and removal, that is a mastectomy. This is the best treatment to avoid the death. You have to perform the mastectomy. So surgical removal of the breast is known as the mastectomy. It may be many types. Simple language, partial and complete. Yes, a small part you are removing, or that is the partial mastectomy. Yes, you are removing entire breast, that is the your complete mastectomy operation. Remember, after mastectomy there is a cosmetic problem, so you will use which muscle? Sir, latissimus dorsi is used as muscular graft for the our reconstruction of the breast. So this is another question. In the after the mastectomy, for the our yes cosmetic problem solution, we use which muscle? Latissimus dorsi. Now look for the next. Yes, focus area for the exam. You have to learn about the structure of the breast. I told you in the videos, you must know the artery supply. No excuse with the lymphatic drainage. And nowadays, a direct question from the breast for the anatomy. Not us, but yes, without the knowledge of the anatomy, you cannot understand the pathology, you cannot understand the medicine surgery of the breast, you cannot understand properly the obs-gynae portion. Now, revision capsule. See here, the previously asked question, breast is which type of the gland? Sir, answer is modified sweat gland. Yes, sir, the breast is modified sweat gland. Montgomery tubercle, sir, these are just opposite. You have to do modified, sir, sebaceous gland. MCQ. Then axillary tail of the spines, I told you, it is the projection from the upper lateral quadrant into the axilla. Yes, foramen of Langer, it is the opening in the deep fascia through which axillary tail of the spines is approaching to the axilla part. Bed of the breast is formed by which muscle? Sir, PES, three muscle: pectoris major, external oblique aponeurosis, and S for serratus anterior. Then suspensory ligament of Cooper is there. Yes, sir. It is joining the skin of the breast to the our pectoral fascia. Okay, sapi plexus, sir, this is the deep lymphatic of the sapi, which is draining the nipple and areola. Sir, arterial supply on the lymphatic drainage of the breast. I told you that arterial supply, the mnemonic is SALI. Yes, superior thoracic artery, acromiothoracic artery, lateral thoracic artery, internal mammillary artery, and the lymphatic drainage of the breast. I created entire flow chart for all of you. Okay. Then breast adenoma, that is a fibroadenoma, mouse of the breast, and breast carcinoma. You must study because it is very, very, very important. One question sure shot in every NEET PG INICT FMG exam, because it is the most common cancer in the world. Angelina Jolie, she got the breast carcinoma. Many famous Hollywood, Bollywood, Tollywood characters, they are having the breast carcinoma. Okay, so remember this one. Surgery question, because anatomy, no question from the breast directly since 5 years. So surgery NEET PG 2023, you have to see there a woman presented with the Birat's 5. What is the Birat's 5? Yes, B for breast, I imaging, reporting, and data system. So you are doing the radiological method, and you are making the scoring system, you are diagnosing the stage. Okay, breast lesion, which of the following is good prognostic factor for the lesion? So now go for the surgery and the pathology. Yes, BRCA gene, these mutations are present in case of the breast carcinoma. So BRCA1 positive, can you see, good prognostic factor. Sir, BRCA, this is related with the bad prognosis. Why it will be answer? P53, which is the guardian of the genome, so it may not be the answer. Yes, and estrogen receptor positive. Estrogen is, if proper maintained, then there is the no chance of the breast carcinoma. But after menopause, the estrogen is decreased, so there is a chances of the our yes breast carcinoma. So estrogen receptor positive means estrogen is presenting, so it is the good. Yes, this will be the answer. And high Ki67, that is a bad prognostic factor. So these are the points I told you in the explanation. Here is the reference. Now try to understand another NEET PG 2020-22 surgery question. Same, I want to tell you, no question directly from the breast in FMG, INICT or NEET PG. So clinical question we have to put here just for your information. You have to read in the surgery. A 59-year-old lady presented with the progressive painless lump. Painless lump. Okay. So you have to think about the breast carcinoma. Okay. In the breast, what is the cause for the following skin changes? So can you see, sir, this is nothing. This is the pure orange appearance. Yes. So it is due to the subdermal lymphatics. Yes, infiltration of the lactiferous duct. So it will lead to the lactiferous duct inversion of the nipple, involvement of the Cooper's ligament, dimpling of the skin, spread of the tumor to the anterior chest wall. Yes, this is the metastasis. Yes, I told you this all the things, important points. Here is the explanation. I just told in one line. Here is a reference for all of you. Now look up the points. Same things are there. Yes. Again, every year NEET PG 2021. Can you see 2021? Can you observe 2022? Can you see the 2023? So definitely in 2024, one question from the breast carcinoma. Sure. Yes. So get ready for that surgery part. Look here. A patient underwent surgery for the breast carcinoma. Okay, sir. She now presents with the painless swelling involving the arm as shown in the image. So here in the arm, can you see the swelling? Breast carcinoma surgery. So when you are doing the surgery for the breast carcinoma, the nearby structures you have to remove, lymphatics also you have to remove. Okay, what is the most likely diagnosis? So during that you are removing the lymphatics, lymph node, so the blood is not draining to the our main circulatory system, so lymph is getting accumulated. Answer is the lymphedema. Please go for the surgery. But yes, anatomy basic points are important. So at the end of this session, yes, the beautiful lines from the our Kung Fu Panda movie. Yesterday is history, tomorrow is a mystery, but today is gift. That's why it is called as present. So enjoy this present given by the God. Thank you very much. God bless you all. स्वस्थ रहिए, व्यस्त रहिए, मस्त रहिए. All the best.